Dear ladies and gentlemen, dear colleagues, students, fellows of the Marsilius-Kolleg, dear Professor Fawzi. It is my great pleasure to welcome you to the 36th Marsilius lecture here in the historic Alte Aula of Heidelberg University. My name is Michael Boutros. Together with my colleague, Friederike Nüssel, we serve as co-directors of the Marsilius-Kolleg. Before I introduce our guest, I would like to thank Katja Sokotnik on the cello and Franz Wassermann on the grand piano. You set the atmosphere this afternoon with Felix Mendelssohn Bartholdy's Song Without Words, and we also look forward hearing from you again at the end of the event with 3 Brazilian dances from Francisca Gonzaga. Thank you very much. The Marsilius-Kolleg at Heidelberg University is quite a unique institution. Founded in 2007, it plays a vital role in fostering interdisciplinary exchange at Heidelberg University. As an institute for advanced studies, it brings together scholars across Heidelberg's academic spectrum: medicine and life sciences, natural sciences, engineering, social and cultural sciences, law, and last but not least, the humanities. Through fellowships, joint projects, and public events such as this lecture series, the Kolleg promotes dialogue on pressing societal and scientific challenges, facilitates mutual intellectual stimulation, and strengthens the integration of research and the public discourse. In recent years, the field of public and global health, the topic of today's lecture, have gained increasing attention and significance among researchers, policymakers, and the public alike. The global impact of the ongoing pandemic, the growing burden of non-communicable diseases, and the implication of climate change for health have all highlighted the deep interconnections between health, social, political, and environmental systems. Now more than ever, health is a matter of global interdependence. In this discourse, the Harvard Chan School of Public Health shines as a global beacon of excellence. It's a synonym for rigorous research, policy relevance, and commitment to improving health outcomes for populations really around the world. Harvard and Heidelberg share a long history of close academic ties, a connection that is particularly strong in the fields also of public and global health. These ties have been deepened over recent years through many research collaborations and institutional partnerships, but also through the personal engagements of scholars such as Till Berninghausen and others who helped to foster a lasting transatlantic and international dialogue and projects in global health science and education. The field of global health, centered at Heidelberg University's Institute of Global Health, has developed really dynamically over the past few years. Today, HI, as it's called in Heidelberg, as a short acronym, is one of the leading institutes for public and global health research and education in Germany, Europe, and probably worldwide. As part of the medical faculty of Heidelberg University, HI is a hub really for global health research and training the next generation of global health scholars and leaders from around the world. Today, we are particularly pleased to welcome a scholar whose work really embodies the global, interdisciplinary, and policy-oriented nature of modern public health research, Professor Wafaie Fawzi from Harvard School of Public Health. Professor Fawzi is the Richard Saltonstall Professor of Population Sciences and Professor of Nutrition, Epidemiology, and Global Health. For more than 3 decades, his impressive research has advanced our knowledge about the benefits of nutritional supplements to increase survival, immunity among adults and children with infection. He advanced evidence and policies about the safety and benefits of integrated nutritional interventions for pregnant women, for infants, adolescents, and researched the interrelationships of food systems, climate change, and planetary health. And that's a topic that we'll also address and talk to us about today. He directed design and the implementation of more than 30 randomized controlled trials and numerous large observational epidemiological studies of maternal, child, and adolescent health, as well as on major infectious diseases. Beyond his research, Professor Fawzi served in many leadership roles at Harvard and worldwide, including as chair of the Department of Global Health and Population, as a member of the Executive Committee of the Center for African Studies. He's a co-founder of the Africa Academy for Public Health. He co-directs the Africa Research, Implementation Science, and Education Network, ARISE, and he has served on many committees of the American National Academy of Medicine and of the World Health Organization and UNICEF. As we have discussed today, we're also very much looking forward to intensifying our collaborations in coming years. Public health and preventive medicine will probably become a much more important focus of our research, teaching, as well as being a key of strengthening our global collaborations. With everything they can offer, universities are key players in addressing global challenges relating to unmet health needs. They have an impact locally, nationally, globally, and today's lecture, I think, is a prime example of international collaboration and the international collaboration, the need for international collaboration in these fields. Professor Fawzi, we are very honored to have you here with us today. Your lecture, The Triple Burden and Transition, Undernutrition, Obesity, and Climate Change in the Lives of Children and Adolescents, touches upon some of the most important challenges of our time. We look forward to your insights and perspective. On behalf of the Marsilius-Kolleg in Heidelberg University, I extend a very warm welcome. The floor is yours.
Good evening, and thank you so much, Professor Boutros, for this very generous introduction. It's a pleasure to be here, really an honor to be at Heidelberg. Thanks to you and thanks to Professor Nüssel for the invitation to deliver this prestigious lecture. Thanks to Tobias Just and his wonderful team for your tireless efforts and support. And to Professor Till Berninghausen, a longtime friend and collaborator, and members of his team, I see many of them here in the audience, for many years of collaboration and many more to come. And for the wonderful musical pieces at the beginning, and I'm looking forward to the one at the end as well. So thank you so much. Professor Boutros noted there has been many partnership efforts between Harvard and Heidelberg, and I'm really looking forward to many more in the years to come. It's fitting, perhaps, to address the triple burden in transition here at Heidelberg, a city and university that's shaped by centuries of transition and transformation. I've learned that Marsilius, the university's founder, championed dialogue across disciplines, a legacy that continues today in the Marsilius-Kolleg. And as we confront many global challenges that face us all, challenges that transcend disciplinary boundaries, it is this commitment to innovation and transformation that is evident here at Heidelberg that inspires our efforts to move forward. So I'll try to cover in the next sort of 40 or 45 minutes these points, a little bit about the triple burden and what it is and why it matters, a brief around key challenges and evidence gaps, brief around solutions that we have been advancing in various intervention studies, a little bit about the roadmap for change that we have also been championing, and some brief conclusions. So adolescence is a period of unique sort of opportunities and challenges. Individuals who are typically facing rapid physical, emotional, and cognitive changes during those 10 years, between 10 and 19 years of age. And a lot of the behaviors that happen to start at this time during this decade have lifelong consequences. So elements of diet, preferences, physical activity, risks associated with drug use or substance use, mental health. Many of these start to take root in those years and have implications for the person, him or herself, during that point in time, implications for their performance in school, but also for their lifetime and for the impact on their families as they transition to form their own families decades later. There are about 1.2 billion adolescents in the world, so that's another reason why we focus on adolescents. It's a large part of the global population. 90% of these are in low and middle income countries. And in many of these countries, in Africa and South Asia and other parts of the world, the developing world, these tend to be 25 to 30% of the population. So really quite sizable to address their needs and opportunities. If one focuses on Africa to start with as a region where we have been particularly engaged, today there are about 1.5 billion Africans. By 2050, this would be 2.5 billion. And the population is rising, but so is the size of adolescents in that continent, on that continent. It's estimated that by 2030, young Africans will constitute about close to 50% of the youth in the world. So whatever we do and learn with African partners and colleagues has relevance for the continent, but relevance for the world as well. We're keen on understanding the health needs, the challenges, the opportunities. And one example that is important to note is sort of the challenge of undernutrition that continues to be an unfinished agenda in many parts of the developing world. Anemia is one example. That's a lot in Africa, but also in South Asia. It is really a global problem. There is anemia everywhere in the US, in Europe, but it's really a matter of intensity and severity. The darker the color, the darker the red, the greater is the prevalence and the severity of anemia. And that's the case among adolescents as well. If one looks at food insecurity, another sort of metric of undernutrition, sort of food shortages, that also tends to be a significant problem. In Africa, about 55% suffer from food insecurity, and 28% have severe food insecurity. And other regions are also similarly affected. I mean, there is food insecurity everywhere, but certainly much more severe in Africa and South Asia, particularly. And if we look at how that is changing over time, it's actually on the rise. As you can see, it is an upward trend, unfortunately, in almost all regions of the world in terms of food insecurity. And also worrying is that the gender gap that is sort of favoring men and boys tends to be also growing wider across the world. So our attention to sort of gender-specific and sensitive approaches to the solutions is important to note. Beyond food shortages, there are concerns also about food quality or diet quality. So not only the quantity, but the type of food that's consumed. There are guidelines that have been established as to what is optimal diet. And typically it is a diet that is rich in fruits and vegetables, food that has micronutrients and other important nutrients that are relevant for immune function for various aspects of health. And globally, 60% are not meeting that sort of recommendation for fruits and about 40% not meeting it for vegetables. Meanwhile, a very high proportion are exceeding the recommendations of the unhealthy foods manifested as red meat or processed foods. Healthy food and healthy diet is relevant for the occurrence of many communicable and non-communicable diseases. Obesity is on the rise in many settings. It is really already quite high in much of North America. It's very high in the Middle East. But it is also on the rise even in sub-Saharan Africa. If you sort of walk down the street, you notice in urban centers a rising tide of overweight and obesity among boys, and even an even higher prevalence among girls. Many of these challenges, undernutrition and overweight and obesity, have implications for the health and well-being of adolescents. The undernutrition is associated with impaired immunity, and as a result, poor development, poor sort of chances of sort of productivity, increased risk of infectious diseases. And overweight and obesity are associated with higher risk of diabetes, cardiovascular disease, and cancers, which are on the rise. In spite of the sort of constrained health systems, they are on the rise in many settings in Africa and Asia. Coupled with this, sometimes referred to as the double burden of malnutrition, there is the third burden, which makes it the triple burden, and that is climate change and the manifestations associated with climate change. So you see that over time, there's been an increase in the number and types of various natural disasters that are attributable to climate change. Floods, droughts, earthquakes, extreme weather conditions are happening everywhere, almost in the news every day. And many of these changes have serious implications for food production, food security. In fact, one of the early work that highlighted the importance of climate change and how it relates to undernutrition and nutritional status in general is the work of Rainer Sauerborn here in the audience. This is from one of his papers, noting sort of the complex pathways, really very simple. It is complex but simple. How sort of climate change ultimately leads to malnourishment among women and among children through reduced production, increased prices, and various other pathways that enhance sort of the risk of these significant problems. There are a number of barriers that stand in the way between trying to address these challenges and the health and well-being of adolescents and of communities at large. And these are some of them. Always sort of at the top sometimes is limited resources in many settings, competing resources and priorities. And so that's something we don't have much control over in academia. We're beneficiaries of some of the resources that might be available, even though it might not be enough. And so we tend to focus really on 3, 4, and 5. One of the challenges is data availability and evidence about the burden of the problem and sort of opportunities to resolve those challenges. Limited capacity to do research and limited capacity to advance the translation of that research. So we focus on training. And the third aspect that interests us is engagement with policymakers in ways that help translate some of these findings into practice. So I'll try to touch on these points today. And a lot of the work has been through an effort that some of us have been advancing. Many colleagues here at Heidelberg as much central to this effort. Through the ARISE network, it's a network that we established about 10 years ago, that bring together institutions in sub-Saharan Africa, particularly 10 countries that are noted on the screen, that meets regularly to examine some of these issues and come up with solutions and engage with policymakers. Heidelberg is a central part of this, and thanks to members of the audience who have been really instrumental to enable this continued efforts with our African partners. So in ARISE, we have these three pillars of effort aligned with the challenges that were on the prior slide. We aspire to do cutting-edge research with a focus on MCH and nutrition and adolescents. We advance capacity building through collaborative efforts with our partners on the continent in universities and in research centers. And we seek to engage with policymakers across the continent in ways that translate and enable sustainable translation of these findings. So I'll touch briefly on some of the work that we do in these three domains. Starting with research, our research focuses on three tracks as we seek to understand and hopefully improve adolescent health and well-being. The first is around evidence synthesis, and our group in ARISE has been focusing on advancing a number of systematic reviews of the literature. Many of them are listed here, many of them are published, and some of them are in the pipeline. And one of the earlier ones has been the first one really looking at a systematic review of the evidence related to school feeding programs. It's a large program or programs across the African continent, reaching about 90% of these programs are led by governments. And the idea of programs is that they enhance school attendance, but hopefully beyond that, improve the nutritional status and learning outcomes of those adolescents. So we were interested to examine sort of the effectiveness of this program that reaches over 65 million adolescents and children across the continent. Briefly, this was the objective. We identified 57 studies. Many of them were intervention studies. They provided a snack or a lunch, various sort of composition. And we were interested to see whether those who received the intervention did better on various outcomes compared to those who didn't. So school feeding resulted in a modest increase in height, 0.3 centimeters, modest increase in weight of adolescents. There is no impact on these outcomes when you sort of standardize through a Z-score, a height for age Z-score, or a weight for age Z-score. It's really very limited impact. Limited impact on hemoglobin levels and anemia, which is a major problem in those settings. Some modest increase also in the number of school days. So one of the objectives is really to increase attendance, because that's, in many instances, adolescents who come to school, that might be their only meal. They might, their only meal or another sort of small meal at the end of the day when they go back home. And so it's a draw to attending school, but really the increase in school attendance was quite modest. The challenge really was that even though it is promising, I mean, these findings are not really an indictment of school feeding programs. They are more, in our opinion, reading the literature and assessing the quality of the evidence, more an indictment of the quality of the programs. In many instances, the amount of food produced was too small. It was still basically carb-based, carbohydrate-based foods in order to sort of increase satiety of adolescents rather than improve sort of their optimal nutritional status per se. So there is a lot more that needs to be done given it's such a large program, and there is already some investment from governments to enhance the quality and hopefully, as a result, the effectiveness of these programs. Several other reviews are completed or underway, and happy to share those references with you if you're interested. But some of the key lessons from the various systematic reviews is that typically integrated approaches are more effective than silo interventions. So that perhaps makes sense, but it's not always evident in programs. Delivery platforms would be important to advance. So some of it is providing adolescents with food through homes, but increasingly using the school as a platform that reaches adolescents is something that is untapped or not adequately tapped. The longer the duration of the intervention obviously is better than a limited few weeks or months, especially if one is aspiring to have an impact on behavior change around knowledge and attitudes pertaining to food and physical activity and other behaviors. And most programs really didn't have as much a monitoring and evaluation element, which is something that we hope could be done much more. Various gaps in the evidence persist. More studies are focused on one aspect of the triple burden, and there is an opportunity to bring these together. Opportunities to approach addressing nutritional status of adolescents through a multi-sectoral approach that engages with agriculture, social protection, and other programs. Important to engage with various stakeholders that touch the lives of adolescents, including parents, teachers, headmasters, farmers, and others. And sort of address the gap in many parts of the world, particularly in the African region. Beyond understanding what's there in the literature, our effort was to sort of fill the gap and through observational data, look at what is the actual current state of health and nutrition of adolescents. So we have done through our partnerships a series of cross-sectional or longitudinal studies that essentially randomly identify adolescents in the community, in the health and demographic surveillance systems, by visiting them at home, or in the context of schools, randomly assessing their health, mental health, sexual reproductive health, dietary intake, anemia, anthropometry, their height and weight, and essentially publish these with the input of junior investigators, and that's also an approach to building capacity, documenting where the gaps are and what we could do into the future. And so some of the key findings from the community-based studies, as I said, these were sort of a random sample of individuals at the community, and the advantage of community-based settings is that it reaches adolescents who are out of school as much as those who are in school. So this was about 8,000 adolescents in 9 communities in 7 countries. Some of the key findings are just a quick snapshot or highlight of the findings. When we look at consumption of fruits, which is a key sort of food, about 70% of boys and girls who were 10 to 14 years of age had only 1 serving a day, sort of less than 1 serving a day, far below the optimal level. That is the same if you go to older adolescents, 15 to 19. If you look at vegetables, similarly, about 40% are consuming at least 1, which is also below the optimal level for both boys and girls, and for older adolescents as well. And if you look at physical activity, which is a key ingredient of sort of the rising tide of overweight and obesity in many communities, more than 70 or 80% do less than 1 hour of physical activity a day. Worse for girls for various cultural reasons, but it is significantly far below the optimal level for boys as well. So these are challenges. Other challenges within the context of the school, if one is to use the school as a platform to reach adolescents, we sort of replicated some of these questions and measurements, but beyond that, so to also engage with adolescents through qualitative research, asked school teachers and administrators, and examined the school environment where students are for many hours a day. These are some of the key findings. these are 79 schools in 5 countries, in urban centers in Africa, Ouagadougou included, Durban. Very few had a school clinic, so the opportunity really to engage with a nurse is not as possible as one might sort of like in settings in the US and Europe. Many challenges around basic facilities. So ideally, many of these should be 90 or 100% sort of toilets, hand washing stations, sort of piped water, a canteen or a cafeteria. These are quite limited facilities within the setting. And changing rooms for girls tend to be also quite limited. And associated with that, challenges around sort of hygiene and menstrual hygiene, particularly, which in many instances leads girls to skip school several days a month on account of that. Other aspects that we looked at is what is the curriculum in the school and whether it includes adequate information around health and nutrition. And if you look at all 79 schools, very limited number of schools had health-related policies, a recommended package of services in the school. And even when those services were really noted in their guidelines, they were not really adhered to. So there would be something in the book at the office of the headmaster, but in reality, when you go around the school, these were not translated into practice. And if one looks at the food that is offered to adolescents in all settings, you would find a predominance of processed food, limited supply of fruits and vegetables, more snacks and unhealthy foods that are available either within the school environment itself at the canteen or in vendors who are around the school. So one of the administrators had this to say: the delivery of school feeding initiatives is patchy in Tanzania. School meals are sometimes inadequate in quantity and nutritional content. School meals focus primarily on energy-dense meals to combat hunger, and is clearly suboptimal. So lots to do in terms of the school environment to be able to enhance the sort of opportunities for kids to do better nutritionally and with respect to physical activity and other health domains. So we took the evidence from systematic reviews and observational studies and aspired to move forward, really. All along, our hope is not to study and observe, but to actually do something that has an impact, and that's a challenge that we all try to advance. And so we have been fortunate to embark on a series of intervention studies that are, and I'll speak briefly about some of them. The first one I'll talk about is a study that we completed in Dodoma, Tanzania, central Tanzania. The capital of Tanzania is Dodoma. We call it the MEGA study, short for Meals, Education, Gardens for in-school adolescents. Essentially, it's an intervention study, a proof of principle study that seeks to enhance the nutritional quality through meals, beans, these are all staple foods, rich in iron and essential fatty acids with some oil, ugali, for those who would know the Tanzanian diet, and some vegetables. And ideally, somebody commented that this is wanting maybe an egg or some fruit. In the next iteration, we are hoping to advance that opportunity. So a school meal is one aspect of an integrated approach. School garden, which uses land the school has to both educate adolescents about nutrition, but some of the produce also goes into the school meal program, which is cooked on premises. A nutrition education, an enhancement of the curriculum in ways that improves understanding of adolescents and teachers about what is an optimal diet through fun curriculum with some games and exercises, enhances physical activity. And lastly, a community workshop that uses that garden at the school also as a model farm for parents to come in, learn from it, and hopefully go back and apply some of these to their homestead. Usually, homes have a space of land around the house, around their home, where they can apply some of these with support, extension services, seeds, and other interventions. So with a study that provided the full intervention, all 4 elements to 2 schools, partial intervention to 2 schools, and standard of care to 2 schools over about a 7-month period. Some of the findings, and these are published in the literature, in adolescents, there has been an improvement in diet quality. So their knowledge and their attitudes, reported intake using a global diet quality score. It's a metric. The higher the score, the better is the diet quality that's consumed. An improvement in weight and an improvement in BMI for age Z-scores. And parental outcomes have also been improved, at least with respect to diet quality, in the sense that parents have benefited perhaps from the monthly sessions and from any information that has been sort of disseminated through the adolescents reaching their homes. In brief, some improvement in knowledge, in actual practices, better diet quality, and some improvement in weight, but not as much on the risk of anemia, which is a significant burden in Tanzania. So we are in the process of designing MEGA 2.0. It's a little bit larger, a little bit more sort of incorporating many of the lessons also in Dodoma with partners at the University of Dodoma and the Africa Academy for Public Health. The second study that we did was to address the burden of anemia. In our observational work, we found that anemia is a significant burden. About 50% of adolescents, 60% in some cases, have anemia. A lot of it is also moderate to severe anemia. This is in Tanzania. It is the same in other parts of the region. And the question that we sought out to examine, really borrowing from the evidence that we and others have done with pregnant women, is the role of supplementation as an approach to improving iron status. And we did that through a multiple micronutrient supplement. It's a formulation that's typically now widely available for pregnant women that includes 30 milligrams of iron and many other nutrients. An iron and folic acid. This is given weekly. MMS is given daily, and standard of care. And the outcome of interest was anemia. This was done in 2 sites, in Burkina Faso, in Nuna, and actually in Kudugu, sorry, Center West, and in Zanzibar in Tanzania. And essentially, these are the 3 arms, cluster randomized trial, 14 schools in each arm in each country, so 42 schools in each country. And these are the formulations, really. It's the same tablet that is available in the pharmacy for pregnant women, which would be efficient, if it works, to use that same supplement rather than create a new tablet. Given daily versus an IFA given weekly, which is the recommended WHO guidance for adolescents. One slide on the findings from Burkina. Essentially, the guidelines recommend iron folic acid, but there was really no impact of giving iron 60 milligrams every week per the guidelines, non-significant, wide confidence intervals. with respect to daily MMS compared to control, there was a modestly significant, or not significant, to be precise, but a sizable impact of providing that. And it could be because it was 30 milligrams given daily, and a lot of the anemia in much of the developing world is due to iron deficiency anemia. It could be due to higher dose of iron, or perhaps because there are other nutrients that are also important for anemia in the MMS. So this was in Burkina. In Zanzibar, also no impact of IFA, contrary to the guidelines, relative risk of 1, essentially, and about 35% reduction in the risk of moderate to severe anemia, in 36%, sorry, reduction in moderate to severe anemia compared to controls. So these are our take-home messages, that there is potentially a role for supplementation. There are context-specific issues. In the context of Burkina, issues around malaria are important, deworming is important. And so even for anemia, one needs to think about an integrated approach rather than a single magic bullet of one intervention. And ideally, beyond supplementation of deworming or of MMS, an approach that educates and enhances diet quality and behaviors, as we have done in MEGA, is even more ideal. The next study that we are, and I'll be brief about each of the following studies. I won't elaborate, just to give you a sense about where we are, where we're hoping to go. This is a study we call COMPASS, essentially a design and evaluation of a school health and nutrition program. The goal is to sort of incorporate feedback and guidance from all stakeholders. So engaging with adolescents, parents, teachers, vendors, and coming up with an ideation phase, really, that putting these sort of ideas together into a prototype and testing that prototype in. So that has been done, and the intervention that we have developed with input from all stakeholders that we are hoping to scale up in a larger trial. The prototype was tested in 2 schools. Is essentially an integrated approach that incorporates whole school interventions, development of a school health and nutrition committee, making use of the school assembly as a means to disseminate and engage with adolescents, a wall magazine that also brings the ideas and the energy and the voices of adolescents into the picture, with a group intervention at the level of a classroom, perhaps in the formal classroom or through adolescent clubs that enhance education, physical activity, and engages with adolescents so that they are active participants in the solution. And an individual level that screens individuals who might have a challenge around overweight or obesity or anemia. And ideally, as we integrate more domains such as mental health, identify those who are in need and refer them to appropriate services. So that sort of three-pronged, three-level approach is something that we hope to take forward in our next work. So these are some of the pictures from that effort. And through this feasibility phase, based on engagement with the stakeholders, adolescents, teachers, and parents, it was deemed appropriate, acceptable, and feasible, with some lessons in all tracks that enables us to improve on the intervention before we take it to a larger number of schools. The next effort really uses some of these ideas as well, but addresses issues around climate needs and climate change. And it's a project that we are just starting in Ethiopia, in Addis Ababa, and in the southern region in partnership with UNICEF and Addis Continental Institute of Public Health. Essentially an effort to integrate climate-smart agriculture as part of the solution to enhance the health and nutritional status of adolescents. And so the questions are, what are the climate-smart practices that are relevant in that setting, and whether it differs between urban versus rural setting in Ethiopia, and how can these be incorporated in a feasible way to impact the health and well-being of adolescents in school. So this is our initial plan to be informed by further engagement with adolescents and other stakeholders. Essentially, the vision is to engage with farmers and enable them to come forward and develop farmer cooperatives or strengthen existing cooperatives if they don't exist, and work with them really to enhance climate-smart agriculture, provision of drought-sensitive seeds, improved agronomic practices, soil conservation approaches, approaches to dealing with waste, various mitigation and adaptation strategies to address climate change, and at the same time yield higher food produced that then is sort of reliable supply and market to schools, that's reliable for schools and reliable for farmers as well. Coupled with enhanced curricula in schools to, between these various approaches, have an impact, hopefully, at the level of the community, improving livelihood of farmers, as well as of adolescents themselves, their knowledge and their nutritional status. A couple other studies that are underway, and many in the audience are active participants in this. Arise Nutrient and DASH. Till Barninghausen is the PI of both, funded by Horizon Europe. DASH is funded by the Ministry of Education in Germany, Ministry of Education and Research, with Mary Monica Sando at the Africa Academy of Public Health. Part of the same wonderful partners that we have, and many colleagues in the audience. I see Irene, Christine, many others that are active in this. Essentially, both of them use platforms in the community and have an observational element. About 8,400 adolescents and 14,000 adolescents in the two studies. Annual surveys that enable us to understand in a more complete way various domains that impact adolescent health, but using these platforms also to already begin to do interventions. And in the recent effort that Irene and others have been leading with TIL, the interventions are designed and ready to be launched, hopefully in the next few months. That will be the case. So exciting efforts that we're looking forward to. I will then sort of try to go a little bit faster into the last two domains around capacity building and policy engagement before I conclude. On capacity building, we try to advance training and education that addresses both sort of the discovery side and the practice side, and see sort of that really as an important aspect of what we do. Already in anything we do, all the sort of data that we generate, as I mentioned, analysis happens by junior investigators on the continent, mentored by senior faculty from Africa and from Heidelberg and from Harvard and other partners as well in Europe and beyond. One example is this project that I'll say a word on. It's a training program that's funded by the National Institute of Health. Unfortunately, was funded because it's recently terminated, as you may know of some of the challenges we're having with our funding. But it's an exciting program that we hope will continue in one way or another, essentially building data science in Africa at University of KwaZulu-Natal with partners there leading, with multiple investigators, multiple PI investigators, principal investigators, Till and myself as sort of part of that central team and engaging with partners in 4 other countries. Essentially seeking to build the capacity through various training activities, short courses, seminars, postdoctoral fellowships. Ultimately, in the final stage, which we are very close to and hopefully will get there, really lead to a development of a new master's program in health data science that enables sustainable capacity building on the continent. Another effort that we are pursuing is this effort. Essentially, we undertook a survey of all schools of public health on the continent to understand their sort of capacity to undertake doctoral public health education, and as a result, hopefully lead to an enhancement in that doctoral education, and through it, other parts of the school would pass. So instructional aspects, institutional aspects, and external aspects of the school were assessed. Paper is published, happy to share it as well. Some of the key recommendations are introduce competency-based education, something that we are always talking about in our settings and increasingly in Africa as well. Strengthen the learning environment in the university as well. And one of the aspects that we are particularly keen on is to strengthen really the functioning of the ecosystem that universities are part of. So we are universities, we do our master's and PhD and doctoral training, but there are opportunities really beyond providing the next generation of trainees who graduate from our schools. There are also opportunities to learn and benefit from an engagement with ministries of health, and same with research systems. So the hope is to translate some of these recommendations into a program, and it's a proposal that we are developing with our partners in Africa. And on policy translation, this is an effort also of ARISE that seeks to bridge research and policy, empower and engage with youth, and catalyze scalable solutions through this Africa think tank. It's a group that has eminent people from various institutions around Africa and around the world. Joy Mauti, who is here at Heidelberg, has been really instrumental in advancing this and part of the Nutrient and DASH enterprise that I mentioned. Was launched in Addis Ababa, June of last year. This is the Minister of Health, the Honorable Mekdis Dabba, Mary Monica Sando, you know this guy, and Professor Ayo at the University of Ibadan, who has been really championing this. It was launched with many partners, leaders in academia and in policy in Addis, and convened again last month in Lagos with a group of young people in the back. That was quite exciting. In conclusion, there are many opportunities that we hope to advance together. This is the Lancet, sort of second Lancet Commission on Adolescent Health that came out about a couple of weeks ago. Identifying the need to enhance demand from adolescents, engage with adolescents, enhance the quality and quantity of data to be able to resolve some of these challenges. And it's something that we are also striving to do. 3 approaches that we hope to advance, continue to advance with our partners on research, enhance research and surveillance of solutions, transform the school environment and platform to be able to have smart schools that integrate agriculture, nutrition, and health, and ideally increasingly do more integrated beyond nutrition and physical activity to incorporate aspects of mental health and menstrual hygiene and other important domains. Second, to continue to build capacity for research and practice, train future leaders, advance data science hubs, and cultivate cross-sector experts, really engage with partners in agriculture, in veterinary, in environmental sector that help promote climate-sensitive approaches, and also continue to engage with policymakers in ways that we have been doing and really more recently began through the think tank that I mentioned. And what better way to do that than to do it with friends and colleagues at Heidelberg? We have had a long-standing relationship, many years, and hopefully many more years to come. As Professor Boutros mentioned, there are efforts to continue to build bridges between us, deepen our relations, and with us, with our partners around the world. This is an exciting time for us at Harvard to continue to be working together and look forward to many more years to come. Thank you so much, and it's an honor to be here. Thank you. Thank you so much.
Thank you very much.
Thank you.
Have to stay with me a minute
Sure.
for a second. Thank you very much for this very inspiring and thought-provocative lecture, and which increases our understanding of the triple burden, but also about the ways in which universities and research can work at international places and internationally in collaboration. This was very remarkable and insightful. Thank you very much for this wonderful lecture.
Thank you. Thanks so much. Thank you. Thank you.
We have a little ritual or visible sign that can remind you of this lecture and of being part of the Marsilius-Kolleg today, which is a medal, the Marsilius medal, which I will show you. It's always a challenge to open this.
Nice.
And it comes with a certificate, which I will read out to you. And, oh, this is too much for me today. The Marsilius Medal is presented to Professor Wafaie Fawzi by the Marsilius-Kolleg of Heidelberg University for his lecture on the topic, The Triple Burden in Transition, Undernutrition, Obesity, and Climate Change in the Lives of Adolescents and Young People, and his contribution to the dialogue between scholarly cultures. Thank you very much.
Thank you. Thank you so much.
And congratulations. It's signed.
Wow. Thank you so much. Thank you. Really appreciate it.